Okay, welcome to the Auditory Learner. This is going to be another one for pharmacology, the second week. Um, First one, I believe, for the second week. For this video, I'm going to do things a little bit different as far as where I'm starting for the outline of the chapters. So instead of starting with chapter 10 and the action potential and things like that and dosage calculations, or chapter 11, um, and the last chapter, which is chapter 15, we are going to do today, at this time, at this very moment, we're going to be doing chapter 4 and chapter 9. Okay, so this is pretty juicy. So chapter 4 is going to be about the autonomic nervous system, which includes cholinergic, anticholinergic, sympathomimetic, parasympathomimetic, adrenergic blockers, and those drugs, the mechanisms, alpha, beta, all that stuff. And then chapter 9 is going to be about the drugs to treat nervous system disorders, anti-anxiety stuff, and the mechanism of actions of benzodiazepines and barbiturates. Okie dokie. So let's start from the top. All right. So chapter 4. Okay, what is we're going to outline the autonomic nervous system. So there is an acronym that I remembered from the previous semester. It's called SAME, and that was for when we were thinking about anesthesia. Yeah, so SAME, S-A-M-E, stands for sensory afferent motor efferent. We are going to talk mostly about the motor efferent part of the autonomic nervous system. Okay, however, we do want to notice some things. There is also the somatic nervous system. Okay, that is, well, the somatic nervous system is part of the efferent motors. Okay, so there's, with efferent motor, there's somatic and autonomic nervous system. And we'll see that the somatic is not as big and deep as the autonomic nervous system. But when we're thinking efferent, we're thinking somatic, and we're thinking autonomic nervous system. Let's start with efferent somatic. That's going to be the skeletal muscles. All right. The efferent somatic skeletal muscle system, nervous system, is going to be basically with heavily myelinated single neurons, where the action potential is quick and it releases acetylcholine. So it's just one neuron going straight, in a connection from the muscles to the muscles. There is no ganglion, which is basically a space that connects two different neurons. So there is no ganglion, it's just one straight one, and it only stimulates skeletal muscle. Okay, that's the somatic nervous system. Now we're going to be talking about the autonomic nervous system, and this is the one that is including the parasympathetic and the sympathetic. So as we learned before, parasympathetic is rest and digest, sympathetic is fight or flight. Okay, so again, this is part of the efferent motor. And so for the autonomic nervous system, efferent autonomic nervous system, which includes parasympathetic and sympathetic, this all affects heart rate, digestion rates, respiration, and sexual arousal. So these parasympathetic or sympathetic increases or decreases these things. Okay, now what we need to know about the autonomic nervous system, which is sympathetic and parasympathetic, is that the pathways for communication in these two systems are very similar in that there are two neuron chains, which are lightly myelinated, and they do have a ganglion, as opposed to, like we just spoke about, the somatic skeletal one. So the parasympathetic and sympathetic have two ganglions. I mean, they have two neuron chains which combine together to form the cell bodies of the ganglion, and they are lightly myelinated, not as heavy as the skeletal, okay? The post-ganglion neurons are not myelinated, okay? They are not myelinated, but they are neurons, okay? The difference here, though, is for the sympathetic fight or flight, when we're talking about transmissions of neurotransmitters, in the sympathetic, there's a pathway where it goes straight to the adrenal glands, which then releases epinephrine and norepinephrine into the bloodstream. Okay, so that's the one where there is no post ganglionic neuron. There is no post ganglionic neuron for the sympathetic adrenals pathway, because the neuron acetylcholine interacts with the adrenals, which then releases epinephrine into the blood vessels. So the way I wrote that here is that the post-ganglion neurons are not myelinated, okay? And that's for sympathetic, parasympathetic, except for the sympathetic part that goes into the adrenals. And adrenal norepinephrine goes straight to the organ and the blood vessels. There's no neuron, okay? Goes into the bloodstream. And that's fight or flight, okay? That's what makes us get going fast, right? So the sympathetic neurons, though, and this goes for both sympathetic neurons, because there's two types of sympathetic and there's one type of parasympathetic. For the sympathetic neuron that goes to the kidneys, and also the other parts of the body, which include the unmyelinated postganglionic and the sympathetic, they release norepinephrine, okay? So when you think sympathetic, you want to think norepinephrine or adrenaline, all right? And then parasympathetic is different. Parasympathetic, which is still part of the autonomic nervous system that we're talking about here, is acetylcholine is the neurotransmitter that's released, okay? And both parasympathetic and sympathetic are both stimulatory or inhibiting, depending on the neurotransmitter and receptors that affects on the organs, okay? Again, let's review. We're not going to confuse the parasympathetic and sympathetic pathways with the neurons with the somatic nervous system, which is the skeletal muscles, okay? Remember that. We spoke about the somatic nervous system. And that skeletal muscles, remember, it's heavily myelinated, and that neurotransmitter is acetylcholine, okay? And that's only stimulatory, okay? Only stimulatory. And again, one thing here is all these are efferent, okay? These are all efferent, including somatic, parasympathetic, and sympathetic. I hope you understand this, Daniel, very well, okay? Make sure you understand this. Make sure you understand what's heavily myelinated, what's lightly myelinated, what the preganglionic axons, how they're lightly myelinated with sympathetic, parasympathetic, and then they're unmyelinated with parasympathetic and sympathetic, except for the sympathetic part, which is the blood vessels and the adrenals. There's no myelination in blood vessels. Remember that. So that's epinephrine, okay? Epinephrine, no myelination. Unless there's a ganglion. If there's a ganglion, there's two neurons. No ganglion, one neuron. All right, get it good. All right, here we go. Now we're going to talk about cholinergic, anticholinergic, sympathomimetic, adrenergic blockers, the common drugs or functions, adverse reactions, All right. Let's start with the cholinergic parasympathomimetic. Okay, so cholinergic, parasympathomimetic. So mimicking the parasympathetic um, pathways, which is rest and digest, right? This is going to make sense because we're going to kind of like connect all the dots here. So the cholinergic drugs activate the nicotinic and the muscarinic receptors, okay, by acetylcholine, which we kind of just went over, okay? And all these drugs increase salivation, all right? And when these patients are using these cholinergic drugs, which are parasympathomimetics, you gotta raise them up very slowly, okay? Now, what are the adverse reactions for cholinergic drugs? We're going to think about SLUD, salivation, lacrimation, urination, defecation. Again, think rest and digest. This exacerbates the rest and digest reactions, okay? What are the contraindications for cholinergics, right? So the contraindications for cholinergics are asthma, hypothyroidism, severe cardiovascular disease, and peptic ulcers, because cholinergics increase the acid secretion in the stomach, okay? Now, there's two types of cholinergic drugs, two types of parasympathetic drugs, parasympathomimetic cholinergic drugs, and there is direct binding and indirect binding types of cholinergic drugs. The direct binding, it releases acetylcholine, right? And it goes directly to the receptor at the ganglia, and it's usually used for glaucoma, xerostomia, and urinary retention, all right? And so, for example, if someone has dry mouth, a cholinergic direct binding drug is going to be Saligen or pilocarpine. It's usually taken 5 milligrams 3 times a day. However, it's not used much because of nausea, sweating, rhinitis, and chills and flushing. Now, let's talk about the indirect cholinergic drugs. All right, so the indirect cholinergic drugs are for prevention of breakdown of acetylcholine by acetylcholinesterase. Okay, so indirect means prevention of acetylcholine by acetylcholinesterase. Some of these indirect cholinergic drugs are used for dementia and Alzheimer's disease, okay? Now, there's some really, really bad cholinergic indirect binding drugs, and those are basically sarin gas and insecticides, and basically it's poison, and they can cause irreversible neuromuscular paralysis. So stay away from all that stuff. All right, so that's direct and indirect cholinergics. Okay, and again, we can see that that direct, there's the choline is binding directly to the receptor, as indirect has acetylcholine esterase to the receptor. Okay, so that's cholinergic. Now let's talk about anticholinergics. All right, those are parasympatholytics, right? So we just talked about parasympathomimetics. So these are rest and digest mimicking. Now, the anticholinergics are rest and digest reducing. Okay, so they inhibit acetylcholine and they do cause xerostomia. Okay, so we went from people salivating and resting, now we're going to anticholinergic. So it stops the rest and digest, right? Inhibiting acetylcholine. These are anti-muscarinic drugs, and these drugs, such drugs like these are called atropine and scopolamine. Sometimes they're used as a transdermal patch. These drugs can be sedating or stimulating. They delay emptying of the GI system and can cause constipation. They relax the muscles and can be used for treatment of asthma, but causes blurry visions. It was used by the Greeks to dilate the pupils, and dilation of pupils is called mydriasis, okay? And we talked about the night shades. but we all know that we don't do that anymore for beauty, okay? And it's anticholinergics such as atropine can be used for pre-oral surgery and also to decrease saliva. Anticholinergics are which inhibit acetylcholine, also can be used for Parkinson's to block tremors. Also can be used for motion sickness and depression of the CNS, in particular for motion sickness of the vestibular inner ear. Now, contraindications for anticholinergics, parasympatholytics. Contraindications for anticholinergics are xerostomia, photophobia, prostatic hypertrophy, and various cardiovascular disease. Great, so that's anticholinergics, parasympatholytics. Now, we are going to switch gears and go into the other types, which are going to be now adrenergic drugs, adrenergic agonist activating, and then there's adrenergic blocking, right? So adrenergic agonists are called sympathomimetics, okay? So adrenergic agonists are sympathomimetics. Sympathetic nervous system, remember? Fight or flight. So mimicking the fight or flight is adrenergic agonists. Activate the fight or flight and overlap with anticholinergics, as we can see, right? Because remember, anticholinergic kind of stops the rest and digest. So it's kind of like another way of saying the same thing. Now, so continuing with adrenergic sympathomimetic drugs, the agonists, right? So this affects all the central nervous system, which causes appetite suppression, alertness, and excitation. There's the beta agonist adrenergic sympathomimetics. So the beta, when you think beta, you want to think about the heart contractility and heart rate. Adrenergic drugs, which are anticholinergics, right? Which are a type of they overlap with anticholinergics or adrenergic agonists. Oh my God. They can cause hyperglycemia and dry mouth. They are also used as a vasoconstrictor in local anesthesia. Hello, epinephrine, right? Boom, fight or flight. And it also reduces bleeding. Treatment, it can be used for treatment of asthma, shock, and cardiac arrest. One thing we need to know about adrenergic agonists, there's indirect adrenergic agonists. And in these cases, this is methamphetamines, and this is used for ADD, right? But they can cause psychosis and delirium in extreme cases. This is why Adderall and Ritalin, which are indirect adrenergic agonists, Adderall and Ritalin fall under the Schedule II drugs, right? Because of the potential abuse. Also, should not be used adrenergic agonists, sympathomimetic adrenergic agonists, should not be used with hypothyroidism because they can cause, and also they can cause a heart attack and arrhythmias. All right, that's adrenergic. Now we're going to talk about adrenergic blockers, right? Sympatholytic. So this is stopping the fight or flight, inhibiting fight or flight, antagonists. Fucking weird. I don't even know if I should have put that in there. Now, these drugs end in olol, right? So these are propranolol. These are beta blockers, okay? The alpha blocking adrenergic is epinephrine reversal, okay? So it can be used for Raynaud's syndrome. Remember, this girl in class had Raynaud's syndrome. She had really cold hands. So that's a little confusing, right? But let's just make sure we get this down pat. Okay, adrenergic blockers, sympatholytic, inhibiting fight or flight, right? Beta blockers, propranolol, right? Then there's alpha blockers. which is an epinephrine reversal, are alpha blockers treated for Raynaud's syndrome. So you have beta blockers, alpha blockers, and those are part of adrenergic blockers. Okay, so there's specificity for these drugs. There's alpha, beta 1, beta 2. When you think alpha, you want to think about blood vessels, usually the smaller ones. When you think beta 1, you want to think about the heart, the larger vessels to the muscles. When you think beta 2, and this is where we want to think about the lungs, albuterol and metroprotenolol for asthma, right? So there you got the OL there, OL, albuterol, metroprotenolol, right? So that's going to be an adrenergic beta blockers, right? Beta 2, right, for the lungs. Also propranolol. Okay. So that's a great review for chapter 4. We're going to go into chapter 9 now. Whew. Chapter 9. Chapter 9 is more drugs for the nervous system. Okay. Now, here we're going to talk about barbiturates, benzodiazepines, non-benzodiazepine, benzodiazepine receptor agonists, which there's only 3 of those. Then there's non-benzodiazepine, non-barbiturate sedative hypnotics, which is only 1 of those, Buspar. And then we're going to talk about drugs that treat depression, right? Drugs that treat depression are SSRIs, SNRIs, tricyclic antidepressants, and monoamine oxidase inhibitors. And then there's psychosis and schizophrenic drugs, and there's 1st generation and 2nd generation. All right. So one thing I want to make sure we hit here is just know the schedule of drugs, okay? We want to make sure we know that barbiturates are Schedule 2 drugs and are also the 1st generation anxiolytics. However, I know that benzodiazepines, which are the PAMs, are not Schedule 2. Benzodiazepines are, if I'm not mistaken, Schedule 4. Yes, sir. So barbiturates have a higher abuse potential because they're Schedule 2, but benzodiazepines are Schedule 4, just less abuse potential. Let's talk about the Schedule 4 benzodiazepines right now. Okay. So Schedule 4 benzodiazepines. Let's get into that. Those are going to be drugs used to treat anxiety and the nervous system disorders. These drugs are Xanax, Valium, Ativan, Halcyon, okay, midazolam, which is Versed. So let me go back, and Xanax is alprazolam, Valium is diazepam, lorazepam is Ativan, Serax is oxazepam, Halcyon is triazolam, and Versed is midazolam. Those are benzodiazepines, right? Those are Schedule 4. Remember, lower abuse potential than the barbiturates. Let's get into more of this stuff here. Before we get into benzodiazepines and stuff like that, let's talk about how anti-anxiety medicine can be used in dentistry and why it might be used. Okay, so 7% of patients refuse care due to fear, and that creates a positive feedback loop. So it goes from fear to avoidance to poor oral health to shame and guilt, and it goes back to fear, avoidance, poor health, shame, and guilt. And I know pain is involved in there too. So that's 7% of patients refuse. So we don't want drugs as alternative to good chairside manners and a relaxing environment while making patients feel like they're in control. We want to make patients feel like they're in control to reduce anxiety. All right. So eventually we want to get them off that because we're nice. Cool. Um, let's talk about, so I just mentioned benzodiazepines, but there's four main dental benzodiazepines, okay? There is Xanax, Ativan, Serax, and Valium, those four, right? Now, out of those four, the ones that are short duration are Xanax, Ativan, and Serax. Those are short duration, so those should not be given the night before. The only one that can be given the night before, because it's a long duration, is Valium. Diazepam can be used the night before sleep, and it can still work in the morning. Okay? So those are the four dental benzodiazepine Schedule 4 drugs, with one of them being a long duration, which is Valium. Xanax, Ativan, and Serax are short duration. Now, let's talk about benzodiazepines in depth a little bit more. So benzodiazepines bind to the GABA receptor, right? It's an inhibitory neurotransmitter. So the channels open for the negatively charged chloride ions to enter the neuron for hyperpolarization, which makes it harder to reach an action potential. Okay, so these benzodiazepines, they do cross the blood-brain barrier and the placenta and are stowed in fat tissue, adipose tissue. If a person is pregnant, a woman is pregnant, she should avoid these at all costs. Why? Because they can cause floppy infant syndrome, and these kids can be born with cleft lips and cleft palates. All right, so benzodiazepine is not good for anxiety-ridden pregnant people. The effects of benzodiazepines are that they are mainly behavioral, anti-seizure, and muscle relaxation. Okay, so the behavioral is basically going to sedate them and reduce the panics and the anxiety. Benzodiazepines are anti-seizure, anticonvulsants as well. Interesting. And they're also used for muscle relaxation. All right, so very, very chill. Inhibitory, right? Inhibits their inhibitions. Anyways, now the medical effects for benzodiazepines usages are anxiety control, okay, insomnia, but it's not recommended because it can cause addiction. Conscious sedation, right? And for epilepsy and muscle spasm treatments. Those are the four medical uses for benzodiazepines: anxiety, insomnia, conscious sedation, and epilepsy/muscle spasms. However, there are adverse effects with benzodiazepines. There's xerostomia, amnesia, thrombophlebitis, and CNS depressiveness like drowsiness, fatigue, muscle weakness, anxiety, which is paradoxical, and nightmares. So the adverse effects of benzodiazepines, there's four. There's dry mouth, there's amnesia, can't remember, and thrombophlebitis, which is vein inflammation. The antecubital vein should be used if it's going through IV. And also drowsiness, fatigue, muscle weakness, anxiety, which is paradoxical with benzodiazepines because it's supposed to treat anxiety. I know I said a lot more there, but that's four. The last ones I mentioned was because those are CNF depressive symptoms. All right, those are benzos, man. All right, let's imprint into our brain now the barbiturates, which are Schedule 2 drugs. And these were the first generation anxiolytics. So sounds like these came out first to treat anxiety. Barbiturates have a smaller therapeutic index because they are more dangerous. Celebrities have died from these, such as Marilyn Monroe. They OD'd on barbs. The oral route is longer acting compared to the IV when it's used for general anesthesia. The central nervous system, then to muscle, and then so it goes from central nervous system to the muscle to adipose tissue, similar to benzos. Long-acting barbiturates are not metabolized or eliminated. They go unchanged through the kidney route. All right, so it's usually for anticonvulsant therapy. So remember the long-acting barbiturates are used for anticonvulsant therapies. Um, and I just want to remind people some names, or remind myself some names of barbiturates. Okay. Some names of barbiturates are pentobarbital, phenobarbital, secobarbital, amobarbital, and methohexatol, or Brevitol. So Schedule 2, we're thinking about talls, right? Schedule 4, PAMs. Schedule 2 are crazy. Anyways, going back. So long-acting barbiturates are not metabolized. They go unchanged through elimination and are used for anticonvulsant therapy. The short-acting barbiturates are used for general anesthesia. However, there are no analgesic properties with barbiturates. They bind to the beta subunit of the GABA receptor. Okay. However, the contraindications are for patients with porphyria, which causes damage to the skin and to the central nervous system. Interactions are similar with benzodiazepines, but it's more serious, especially when combined with alcohol. So, if you're taking barbiturates and then you take these other drugs, it's going to reduce the effects of the barbiturates. These are acetaminophen, beta blockers, birth control, doxycycline, estrogen, steroids, antidepressants, and warfarin. So those drugs are going to reduce the effects of barbiturates. However, if you're taking disulfiram or propixophene or phenytoin, those are going to enhance the effects of barbiturates. Another thing that's going to enhance the additive central nervous system depressants is with barbiturates is if you're taking alcohol, opioids, or monoamine oxidase inhibitors, which I believe are antidepressant drugs. Let's make sure. Yes, depressive treatment. Okay. Let's talk about what I mentioned before. There's a non-benzo, non-barbiturate sedative, which is Buspar. Buspar is an unknown mechanism that involves serotonin. That's all we know. Mechanism is slow, which means there's a 1-week onset for Buspar. Strong sedation, but still reduces anxiety. Then there's non-benzo, benzo receptor agonists. These are sleeping pills, okay? So when we're talking about sleeping pills, you want to think non-benzo, benzo receptor agonists. There's only 3 drugs for this, which is Ambien, Sonata, Lunesta. Ambien is zolpidem, Sonata is Zelpalon, and Lunesta is escopetalone, whatever. The residual tiredness the next day can rebound. Insomnia and headaches and dizziness can occur. And then there's melatonin, which is a natural over-the-counter. Still pretty potent. So we just talked about some benzodiazepines and barbiturates. Now we're going to go back to benzodiazepines, and we're going to talk about the addiction and tolerance and how it's related to alcohol with benzos. So for addiction and tolerance of benzodiazepines, if it's used for longer than 1 month, it can be serious in terms of tolerance of addiction. Okay. Again, benzodiazepines are Schedule 4, but they still come with a black box warning. Tolerance can develop within weeks. Overdose is rare, but if it is going to happen, then you might want to use flumazenil, romazicon, as the antidote. Also, smoking diminishes benzodiazepine effects by reducing CYP2C, so it speeds up the metabolism of the benzodiazepine, which is induction. Alcohol, barbiturates, and anticonvulsants add on to the effects of benzodiazepines. Okay, that's bad. That's how people get hurt, killed, or hurt others. Now, let's talk about alcohol, which is an ethanol, right? There's addiction to alcohol. Alcohol is also an anxiolytic, anti-anxiety drugs. People know that's why they drink. Alcohol binds to GABA receptors just like benzodiazepines. However, instead, there's a specific subunit in the GABA receptor. Alcohol binds to the alpha subunit. All right. alpha subunit. Alcohol binds to the alpha subunit. Okay. Moving forward, alcohol, right? Benzodiazepines can be used for alcohol withdrawal symptoms. However, it can cause tremors, headaches, and anxiety. So that seems to be it for chapter 4 and chapter 9. Okay. I do want to just say some things here real quick for questions. If we're going to be asked a question to be matching, right? Here's the example for what was correct. So Abiligy is a second generation, or Abilify is a second generation antipsychotic. Alprazolam is a benzodiazepine. Zoloft is an SSRI. Effexor is an SNRI. Valium is a benzodiazepine. Ambien is a non-benzodiazepine benzo sleeping pill. And methohexital is a barbiturate because it has the tol. So that being said, let's just kind of review here, okay? SSRI, selective serotonin reuptake inhibitor. SNRI is serotonin norepinephrine reuptake inhibitor. Okay. Then we want to just know these drugs. Okay, so barbiturates are the tols, which are schedule 2. Benzodiazepines are the PAMs, right, which are schedule 4. Then we're going to talk about the sleeping pills, which are non-benzodiazepine, benzodiazepine receptor agonists. Long name, but those are sleeping pills, and there's only 3: Ambien, Sonata, Lunesta. There's only one non-benzodiazepine, non-barbiturate sedative hypnotic, which is Buspar. We talked about that earlier. So the depression, so remember, SSRI, SNRI, tricyclic, and monoxetamine, those are all depression treatment drugs. Okay, so when we think about Zoloft, that's a depression treatment drug. That's an SSRI. Okay. Venlafaxine, which is Effexor, that's an SNRI. Okay. Tricyclic antidepressants are amitriptyline, and monooxidase inhibitors, monoamine oxidase, are isocarboxyd, Marplan. Not sure how much he's going to ask us on the test about first-gen and second-gen antipsychotic drugs, but first-gen antipsychotic drugs would be things like chlorpromazine or chlorpromazine. Chlorpromazine is thorazine, chlorprixine is tartcan, whatever. Second-gen are Abilify. Okay, hello, that's a second-gen. Abilify, which is aripiprazole, is a second gen. Yes, that was one of the questions. Abilify is a second gen antipsychotic. So again, Abilify, second gen antipsychotic. Alprazolam, benzodiazepine. Zoloft, SSRI. Effexor, SNRI. Valium, benzo. Ambien, non-benzo, benzodiazepine sleeping pill. Methohexital is a barbiturate. All right. That was chapter 4 and chapter 9. All right. So let's make sure we know all this very well. We'll do the next one later.